orthopedic surgeon and sports medicine physician, and today I'm talking about painkillers and opioid use. The good, the bad, and the ugly. So let's just jump right to the ugly part of opioid use, because there are people who are overdosing and dying from these things probably on a daily basis. Some of the more famous people who've died, Prince, and most recently, Tyler Skaggs. So for those of you who don't know, Tyler Skaggs was a pitcher for the Los Angeles Angels. He was found unconscious and unresponsive in his hotel room, and the autopsy showed that he died as a result of alcohol and a high level of opioids, including fentanyl, in his bloodstream. So some of you might wonder how exactly these people died from opioids. So opioids have a number of effects, of which pain relief is but one. When talking about opioid medications, I like to summarize their main effects into three basic areas. The major effects of opioids include effects on your brain, effects on your pain, and effects on your gut. In the case of Tyler Skaggs, he died because he aspirated, meaning that he choked on vomit after having consumed an excessive amount of opioids, including oxycodone, oxymorphone, fentanyl, and alcohol. All of these things are known as respiratory depressants. In other words, they decrease your body's ability to breathe. They slow down the rate and they decrease your level of consciousness, and they also decrease your ability to protect your airway. In Tyler's case, because he had consumed all of these things, he had a decreased level of consciousness where he was not able to protect his airway. What I mean by that is that basically he was unable to react to the gag reflex. And because his airway was obstructed by vomit and his level of consciousness was so low that he was unable to react to this, he basically choked or asphyxiated on his vomit because he was unable to start coughing to rouse himself from his decreased level of consciousness. So this is just one way in which you could die from an opioid overdose. However, this is not the only way that you could die. As I said before, opioids can serve as respiratory depressants. So basically, they're gonna decrease the drive in your brain to breathe. There are a number of processes in your body which are what we call autonomic processes. One of those processes is breathing. Your body just does it automatically, knowing whenever it has to do so. But the rate at which you breathe is controlled by your brain, the central nervous system, the main computer. If you slow and decrease the function of the computer enough, then the drive to breathe will likewise be depressed or slowed by the action of the opioids. If you lower this enough, there really is no drive for you to breathe. Even though you are dying from lack of oxygen, your body just doesn't breathe. It just doesn't feel the need to do it. Another way in which you could die is cardiovascular depression. It all comes back to the main computer. If you slow the computer enough, then all of the functions that are controlled by the computer will likewise be slowed, and eventually they just may stop. With enough opioids on board, your heart will just stop beating. So I've just talked to you about the ugly part of opioids. And before I get to talking about the bad, the addictive part, and the good, what we use them for, let's just talk a little bit about opioids in general. So what are opioids anyway? Well, opioids are a class of medication which are derived from the opium plant. That's right, the poppy. The same poppy from which heroin is derived. And this is a class of medication that has been created for its analgesic properties. In other words, it's a medication that we use to control pain. The pain medication in this class of drugs, which is most commonly known, is morphine. And this is a pain medication which binds to pain receptors in the brain to create an analgesic effect. In other words, a pain relieving effect. Morphine is not the only pain medication in this class of drugs. There are a number of morphine derivatives in this class of medication which all have different relative strengths of analgesic effect. In other words, these different medications are either more or less effective at relieving pain than morphine. Some of the more commonly known medications include hydromorphone, fentanyl, Oxycontin, and codeine. And so you can appreciate the differing strengths between these medications, here are the relative strengths of some of these narcotics. If we assume that morphine has a relative strength of 1, tramadol, a newer narcotic agent, has a strength of 1/10 that of morphine. Hydromorphone, a synthetic derivative of morphine, has a strength of 4 relative to morphine. Fentanyl, which is quite widely covered in the news these days, has a relative strength which is between 50 and 100 times as strong as morphine. Recently, some street drugs have also been laced with carfentanil, which is another morphine derivative, which is most commonly used in the veterinary profession as a pain relieving agent. Carfentanil has a relative efficacy of 10,000 times the strength of morphine. And just so you understand how narcotic analgesic medications stack up against non-narcotic analgesic medications, such as non-steroidal anti-inflammatories, I'll give you the relative efficacies of some of the most common forms of those drugs as well. The relative effect of ibuprofen is 1/222nd that of morphine. Naproxen is a bit better. The relative effect of naproxen versus that of morphine is 1/138th. And although it's not a non-steroidal anti-inflammatory drug, I'm going to throw Tylenol in there because it's like the most commonly used pain medication of all. The relative efficacy of Tylenol is 1/360th that of morphine. It doesn't really hold a candle to morphine, in terms of pain relief anyway. Well, as I said before, opioids are very effective pain relieving medications, and they are just basically way more effective than the alternatives. And although they do have a number of side effects, their ability to relieve pain is just so good that we use them anyway. So recently there's been a lot of news coverage about opioids and one of their side effects, which happens to be their addictive potential. And though not all narcotics have the same degree of addictive potential, this is a potential problem for some of the medications that we do use and prescribe. So if there's an addictive potential to some of these medications, you might be wondering why we use them anyway. Opioids are very effective pain relief medications, but they are designed for use in clinical situations. In other words, in a controlled setting, a hospital, a doctor's office, or something like that. That's why you need a prescription to obtain them. Medical expertise is required to properly use and prescribe these drugs. In this day and age where everybody is looking for the quick fix and nobody wants to experience any kind of discomfort, there is a strong desire for us to prescribe medications to patients which minimize greatly or completely eliminate all traces of pain when patients are injured or ill. Opioid narcotics are a medication that we use to do this. So given all of the bad and the ugly things that I've told you about narcotics, what are some of the situations where we might use these medications or prefer to use these medications? So as you know, I'm an orthopedic surgeon and I perform orthopedic surgeries on patients. Narcotics are medications that I use in my practice to treat moderate to severe pain. Usually, this is pain that's associated with or which follows surgery of an orthopedic nature. However, this can also include injuries that we have not yet operated on or that we have chosen not to operate on. Usually, when we prescribe these medications, we are prescribing them for use during the acute period or a short period of time. Normally, these are not medications that we would like patients to use on an ongoing basis. There are only a few problems or a very narrow set of indications for which we would prescribe narcotics on a long-term or ongoing basis. The most common indications for which we might prescribe these medications on an ongoing basis include terminal cancer or severe malignant chronic back pain. But normally when we prescribe these medications, we are intending them to be used for only a few days to a few weeks duration of time. As physicians, our expectations are that the requirements for their use will decrease over time as the pain symptoms alleviate or resolve. The most common narcotic medications that we might prescribe in order of their relative strength include Tylenol 3 with codeine, Tramadol, and hydromorphone. In addition, some physicians may also prescribe morphine, Percocet, or Oxycontin. However, we prefer not to do that because those medications in particular are associated with a higher incidence of narcotic addiction. In my particular case, for musculoskeletal injuries or the normal post-operative moderate pain, I would prescribe Tylenol with codeine or TRAMADOL. When the pain is more severe, I prefer instead hydromorphone because of its relative analgesic strength and because of its decreased addiction potential. Before we prescribe narcotics to patients, there are a number of things that we have to consider. One of the first things that we need to consider is the expected severity of the pain. If the pain is of a minor nature, then that means I am more likely to use a non-steroidal anti-inflammatory medication as an analgesic rather than a narcotic agent. However, if I anticipate the pain is going to be of a moderate to severe nature, it's going to be quite intense for a short period of time, and I don't think that non-steroidals are going to cover that pain adequately, then I'm going to prescribe a narcotic analgesic. If you were to consider a pain scale from 0 to 10, with 0 being no pain at all, and 10 being the worst pain imaginable, where you would reach into your pocket to give me money to cut it off right here and now with a rusty butter knife, on that scale, 10 being that, I would prescribe a narcotic analgesic if the person was expected to have 8, 9, or 10 out of 10 pain on that scale. Another thing that we have to consider before prescribing narcotics is the anticipated duration of the pain symptoms. Normally, narcotics are something that we prescribe for pain symptoms of a short duration of time. In other words, we expect the pain to only last from a few hours up to several days or maybe a few weeks at most. But if we expect the pain to be of a long duration, our preference is to find some other method of analgesia other than a narcotic opioid. On a more personal note, another consideration is the patient's tolerance to pain. And I know what you're saying, because I hear it all the time. I have a high pain tolerance. Stop. Let me let you in on a little orthopedic secret. If you think that you have a high pain tolerance, in the orthopedic community, it means the exact opposite. If someone says to us, I have a high pain tolerance, the minute those words come out of their mouth, we know that it means the exact opposite. Although at this moment I am not aware of any studies that definitively show this, ask any surgeon that you know what they think when someone says those words to them. The people who tend to say that to us are the ones who tend to have the highest requirements of narcotics for pain relief following surgery or an injury. Another important issue that we have to consider before prescribing narcotics to a patient is the presence or absence of an addictive personality in the patient. As I mentioned before, narcotic analgesics are derived from the opium plant, which is the same plant from which heroin is derived. And just as heroin is a drug which has a highly addictive potential, there are some narcotic medications that also have a highly addictive potential. If you combine a medication which has a highly addictive potential with someone who has a highly addictive personality, then odds are you might increase the chances that the patient might become addicted to the medication that you prescribe. Another personality trait that we need to consider before prescribing narcotic analgesics is the presence of anxiety. Those patients that have a tendency toward anxiety tend to present themselves in a highly emotional state. The fight or flight state within which these patients often find themselves tends to make them more responsive to painful stimuli. In other words, these people tend to feel the pain more. Or maybe they just think they feel the pain more, but either way, they feel it more. And one final thing that we need to consider prior to prescribing narcotic analgesics is a history of ethanol or drug abuse in the past. And this basically comes down to one issue: Previous alcohol or drug use means that the patient is more likely to have a tolerance to the medication that you will prescribe. The reason for this has to do with the patient's liver. With a history of alcohol or drug use, the person's liver will have more of the enzymes present that will metabolize these compounds in the blood. If the narcotics are metabolized quicker, there will be less of these drugs available in the bloodstream to provide the pain-relieving effect that the patient is looking for. Therefore, they're going to need more of this medication to get the same effect that somebody who had not had previous alcohol or drug exposure would require. So knowing all that, then how does a situation like Tyler Skaggs occur? I don't know Tyler Skaggs, so I do not want to say for a minute that this is what I think happened to him. However, in general, I can think of a few situations that might lead to a negative outcome such as that which happened with Tyler. If the person thought that they were going to have perhaps a 1 out of 10 or a 2 out of 10 pain, and then they suddenly found that the pain was 8, 9, or 10 on 10, this might cause them to increase the amount of narcotic analgesic that they were taking without their doctor's permission, and this might lead to a situation where an overdose could occur. Sometimes, patients just may choose to self-medicate. And when I say self-medicate, I don't actually mean that they use the prescribed analgesia to address their pain symptoms. Instead, they may choose to supplement with something else, such as alcohol, or another drug that may decrease their level of consciousness or their ability to protect their airway. Now, when I say supplement, this can be intentional because they thought that the analgesic was insufficient, or it can also be unintentional. Oftentimes, people just don't know that there are interactions between the things that they are ingesting. For example, if somebody was taking a narcotic analgesic for some kind of injury or surgery, and then they just happened to go out with their friends, and when they're out with their friends, they thought they might have a drink or two. Well, guess what? Alcohol is a central nervous system depressant, and narcotics are also a central nervous system depressant. When you add the two together, you have a large central nervous system depression effect, i.e., your body doesn't want to breathe, you have a decreased level of consciousness, and your body does not want to protect its airway in case you should vomit or throw up. It's generally a good idea when taking narcotic medication to not use any other form of medication unless you have cleared it with your physician. It is also a good idea to not drink alcohol.
So how would it have happened that Tyler Skaggs had all of those different medications in his bloodstream plus alcohol?
Okay, so I'm not saying this is what happened to him, but I could think of a number of different ways. So number one, he maybe took all 3 of those medications. Although that's very unlikely because 2 of those medications are quite similar, and he wouldn't get a prescription for the 2 of those different kinds of medications, and he probably wouldn't have a prescription for all 3 of those medications, and certainly whoever prescribed medications to him like that, they wouldn't have allowed him to take all 3 or recommend that he take all 3 at the same time. So we can rule that one out. What more likely happened is that he did not have a regular approved pill to take. In other words, he probably took something that was manufactured, not by a company, but by an individual. So typically what happens with these kinds of things is that you'll have somebody who is an illicit drug supplier, right? So this is somebody who's making drugs on the street. They know the chemistry on how to make these drugs, and so they want to make a combination that's going to give people a better high or be more powerful than the combination that they're going to get from the next guy down the street. So they're going to experiment, and so they'll know the chemical formulation for oxycodone or Oxycontin or whatever. And so instead of making a straight pure medication, they'll say, okay, well, I'm going to make, in this batch, I'm going to make it 80% Oxycontin, 10% oxycodone, and another 10% fentanyl. That's what they'll say. And that's what they'll do. And they'll mix those all together. And then you can buy a pill press off of the internet. So they'll mix the powders together and then they'll press their own pills, right? And so somebody will buy that on the street, not knowing what they're getting, or maybe they do know what they're getting, but somebody will buy it on the street, and then it will be a combination of all those different medications. If you give it to somebody else who doesn't know, they may take it thinking, oh geez, I'm just taking oxycodone, I'm just taking an Oxycocet, I'm just taking Oxycontin, I'm just taking whatever. And they'll not know the various amounts of all these different medications, or even the fact that they're taking multiple medications. And so then they'll take it. He was also found with alcohol in his system as well. So again, I'm not commenting on him, but I would venture to guess that he got it illicitly from somebody, and the medications give you a feeling of euphoria, and particularly if you don't have a lot of pain receptors that are requiring the medication. So if the medication is circulating in your bloodstream and it is not being consumed by pain receptors, that leaves more of it available in your bloodstream to be consumed by the pleasure centers in your brain. So the less pain that you have, the more euphoria it's going to give you. So if you want to feel good, you can take that. And generally, when people want to feel good, they drink a little alcohol too. So, if he wanted to feel good, took this medication, this illicit medication, because it's not formulated by a company, and he took that with alcohol, this is something that could easily have ended up the way it did for him.
So what then is the bridge between a drug addict and a regular person? Because most people don't want to become a drug addict. They don't want to be addicted to narcotic analgesics. At this present time, we do not have a good class of drugs for moderate to severe pain. And so, narcotic analgesics are it for now. But we know that they have an addictive potential. So what does this mean? This means that the bridge between a drug addict and a healthy person is pretty narrow. And it's on a slippery slope with a really steep incline. So if you're asking, Doc, how do I deal with this because I don't want that to be me? Here are a few recommendations that you might want to employ that will reduce your chances of having this happen to you. Rewind this if you have to make sure that you didn't miss anything. And don't say that I didn't tell you. Number 1, be active. Those who are active are more healthy, have a higher lean muscle mass, have better body awareness, and are less likely to become injured. Number 2, employ active prehabilitation and rehabilitation wherever possible. This means that when you exercise with intention to make sure that you make yourself stronger and more mobile, to prepare yourself for injury whenever it may come. And when you're injured, you use exercise to make yourself better rather than waiting for somebody else to do something to you. Number 3, be sure to follow our instructions on the proper use of narcotic analgesics so that you don't find yourself on the slippery slope towards narcotic opioid addiction. Be sure to use medications like Tylenol and non-steroidal anti-inflammatory drugs as your baseline analgesics so that you only need to use the narcotic analgesic for breakthrough pain. In other words, you only need to use it to shave the peaks off the mountains.
And also, if you don't want to become addicted to these medications and or even possibly die from taking these drugs, don't take street drugs where you don't have any idea what's in them.
This has been a very serious topic, and I hope that I've provided you with some insight as to why we might prescribe narcotic analgesics And I hope that I've given you some information to help you avoid becoming that person that is addicted to narcotic opioid medication. If you enjoyed the video, be sure to give it a big thumbs up, and please, in all seriousness, share this with someone who you know, because you do not want them or yourself to become that person who is addicted or dead, because that also is a possibility. And as always, that's been a word, although a serious one, from Dr. Chris, not your everyday ortho.